I'd like to welcome everyone to our session today on symptom control management and getting over COVID-19 for people with Parkinson's. I'd also like to give our tremendous thanks to IL for sponsoring this meeting, which is so important to all of us, some people who are working in isolation, and of course some of us who are even doing other people's jobs as well as our own as they are working on wards and intensive care. I'm very privileged today to be with an expert panel to share with us their own experiences of working with people with Parkinson's and COVID, and also going forward, how are we going to manage the rehabilitation of these people with Parkinson's? And also, people are getting better. And I think it's very important that that note is delivered. I would also like to thank our Neurology Academy today and Sarah and her team for all their IT expertise and helping us in bringing this all together. After each speaker, there will be time for questions. I will just introduce the speakers very briefly. Their bibliographies can be found on the Neuro Academy website, and this is purely just to avoid delay, but also it's a well-known panel to all of you. What we're going to be covering today is Annette is going to be looking at her case studies and personal experiences of managing COVID. Alison is going to be looking at case studies and her personal experience of COVID, of people with Parkinson's and deep brain stimulation. Louise, Ebenezer is going to look at recovery, which is possible for people with Parkinson's who have had COVID. And Fiona Lindop is going to look at and take us through what the papers are saying on post-COVID-19 and the importance of rehabilitation. So without further ado, I would like to open the meeting and thank you all for joining us here today and ask Annette.
Thank you very much, Patsy, for that really nice introduction. What I would like to talk about this afternoon is really my experiences of what's been happening for me over the last 2 months. So I have been a Parkinson's nurse now for over 22 years, and I haven't been on the ward for an awful long time. But over the last 2 months I have been, and I've been working on a COVID ward, and I've just got off shift this afternoon there, so that's why I've still got my bunches in, because that's the only way I found to keep my mask in place without hurting my ears. So I just wanted to really share with you my experiences really of being on the ward, what it's like to be redeployed, I suppose, for people who haven't been on the ward for an awful long time, and share 3 cases with you of people that I've looked after, particularly over the last 2 months. So life on the ward. I must admit, when we talked about, when I was told by the director of nursing that some people need to be redeployed, and certainly my team would be part of that, I was very conscious that I didn't want my team to go onto the wards if I wasn't prepared to do so myself. So I must admit, I've lost 2 members of staff. 1 member of staff went into infection control. One member of my staff went to work on another community hospital. And our office is in the general hospital, and across to our office is another office that's run by a consultant. And I've worked with her for an awful long time. And she told me that the ward that she works on, which was the elderly medicine ward, had been converted into the local COVID ward, where people would go from intensive care to that ward, and they'd either go there for rehab or to unfortunately die. At that point, it just happened. So that news just come through that day. She was telling me how anxious the staff were, how concerned they were about the COVID-ness of the ward and how they look after staff, how looking after patients. But what also struck me was the fact that she said a lot of the staff couldn't work on the ward because they were at greater risk. So lots of people had been moved, but also people who'd been on bank shifts there had cancelled because they didn't know what to work on that ward. And so I volunteered. So I volunteered to go and work on Ward 12 because it's somewhere I knew very well. So things I had to learn really quickly were these. So I remember the days where I was, doing a drugs round with a drugs trolley, and, the old days we had big cabinets everywhere. So for me, the first thing that changed very much was nerve center. So this thing here at the bottom, you have an iPhone. So each shift you go on to, you log on as yourself, and actually that gives you all the patients on your ward. It tells you exactly what the scores are, what they've come in with, what the plans of care are from everybody's perspective. And this is a really important thing that you have, that you kind of work your way through. So this was a very new bit of new technology for me to manage. The new scores I'll come on to a little bit again, because we'll all remember doing rounds where we took bloods and temperatures and blood, blood pressures and temperatures and pulses and wrote it down on a chart. Those charts go on the end of patients' beds that often could be left and missed. But I'll show you how news has been really exciting. E-meds. So e-meds again is done by an iPad now, where you go around the ward with your little iPad, you put the patient's name in, and it's fantastic. So as a prescriber and as an administrator, I've had to learn how to use e-meds very quickly. And Omnicell, I don't know how many of you have seen Omnicell, but this big thing here is now in our like a treatment room. So this is here now. You put your little fingerprint in it. It comes up. It says "Welcome Annette hand," and it gives you all the patient's names. You can pick out drugs from that, and you have to find medications, and also some of the controlled meds are in there as well. So again, all these things were very new to me, along with pumps. I don't know about you guys, but I remember when I was doing an infusion or IVT going through, it was like a guess rate with the drip rates. We didn't have pumps in my day for some of them, so it's great to have to use pumps, but also some of the new paperwork that's come through. But the ward staff were fantastic and supportive. They didn't expect me to go on and knew everything. They knew I'd been off the ward for an awful long time, and actually these things that that I was quite anxious about, but it was really supportive. I had staff there to help me through the process. The things that didn't change at all is patient care. It doesn't matter how long you've been off a ward or how long you've been off a department, actually looking after somebody, watching somebody, caring for somebody, talking to somebody, is just the same. And for me, actually, I've really enjoyed the last, couple of months providing that basic care that I haven't probably done for an awful long time. The real challenge, though, for me was the PPE. Having to do this behind a mask, behind goggles, behind a gown and gloves, not having that personal touch. And when people can't see your face and can't see how you communicate and can't see your smile or reassurance, often people are older who can't hear very well as well. So again, all those things are really challenging. And I think for me, I just wanted to be able to take my gloves off and hold somebody's hand sometimes, and I couldn't do that. And that was very frustrating and very difficult. So for me, actually, I've had a fantastic couple of weeks, a couple of months around the wards, and something, I will never forget. I've never known anything like it in my whole entire life. But if people are asked, will you go and work somewhere else, or will you look at being redeployed if things happen again? Please, don't feel too anxious about it. The ward staff are amazing, and they were so grateful for my support, even though it's been a long time. And I must admit, even though it's been really challenging and very upsetting some days, it's been something that I will keep with me for the rest of my life. So the news scores, I don't know how many people out there are aware of the news scores that they're using on the wards now. And it's great because when you go in, you've got your little nerve centre and you've got your little iPad, you go around. And these are things that are really helpful when we're looking at particularly things like COVID and how we manage that, or how we identify people who are deteriorating very quickly. So this is a news score that's came out some time ago, but this is recommended now by the Royal College of Physicians, and it's there. So what we're looking at is a number of observations. First of all, we've got top is the respiratory rate. You then look at saturation levels. And again, this is in scale 1, scale 2, so some slight differences. And again, that would be different if you've got somebody with COPD or with asthma, then saturation levels would be expected to be lower than somebody who hadn't got those conditions. You then have people on oxygen or air. You've got your blood pressures, you've got your pulses, you've got your conscious level, you've also got your temperatures. Also, we're monitoring for pain, and we're also for skin coloration as well. So when you put your scores in, or when you do your observations, it'll come out at a rating scale, if you like. And if there are problems, if actually their oxygen levels are dropping and the saturation levels are below 91, it'll come out as a score 3. If you then find on they're on a infusion, or they've got a cannula on, that will then bump up the score. Their blood pressure again. So these things are put in real time. So automatically it's flagged up if somebody's deteriorating very rapidly. Because we're all linked in on the ward, it means that the observations are reported straight away to the nurse in charge, or even to the doctors. And if the doctors aren't on the wards as well, they will ping up to them if there's urgent action needed. So actually adding all these things together, you didn't have to be calculating yourself. It'll bring up automatically what some of these scores will look like. So just to, again, be aware of those things if you ever look at the wards again. For me, this is something that I hadn't looked at for an awful long time. So my case studies. First case study is somebody, and I'll show you the kind of the bar at the top. So C19 means the gentleman's COVID positive. This is not for resuscitation. He's a falls risk. He's a diabetic, and critical meds is because he's also got Parkinson's. So this is a gentleman who was 64 years old, who came in being generally unwell, had a fall, and increased shortness of breath. He was a diabetic, He was diagnosed with Parkinson's back in 2018, and he wasn't on a great deal of Parkinson's medication, just on co-carbidopa 125 3 times daily. But as this part of the mission, he was also diagnosed as a new COPD. When he was in our emergency hospital, he had to have CPAP to help with his breathing. And because of his COPD, his oxygen levels, his saturations were anywhere between 88 and 92. That's what we're hoping to achieve. So this guy had to be on 40% oxygen to start off with. As an inpatient, he had a couple of falls. He had some loose stools as well, which is extremely common with COVID. And again, some confusion. And the amount of loose stools and delirium I've seen with COVID is quite unreal over the last few weeks. And this was his news score, so just to show you really what that means. So this means he's got an early warning score of 8, obviously, and that's red, and that gets reported through. So you can see his respiratory rate here is up in the red. You can see his saturation levels here on the 2nd of May at this time in the morning. Okay, is 92, and then it drops to 88. So you can see how it changes color, and we'll give another alert. We've got the heart rate going through, the blood pressure. He's alert, he's conscious, his temperature's not up, he's not in any pain. Here he's got a mask on, but he's needed CPAP, and again he's got the mask back on again. And he's passed you, and you can see he's got normal appearance. So you can see here this guy isn't doing great. His saturation levels are dropping. You can see his respiratory rate is up. All right, and again, this gentleman certainly needs some more support and care. So what was our plan going to be for him? Well, over the time, we need to make sure we weaned him off the OT. We need to push his oral fluids. We really need to get the physiotherapy involved. And for me, the Parkinson's medication was really important. Even though this gentleman had only been diagnosed for, a couple of years, he was still needing those medications regularly. Again, remember, he's got loose stools. So in my head, I had several options, and I always have option A, B, and C in my head, even though I don't know what those options sometimes will be, but I always have plans that I have that I think, okay, what happens if, what next? So my first point of call would have been to crush his co-carbidopa, because for me that works better, works longer than usual dispersibles. And again, if he's got diarrhea and I've got worried about fluctuations, I can crush his levodopa dose. No, hopefully he'll have that, boost from it, and I won't need anything else. If things deteriorated, though, I could have used dispersibles, or I could have thought about the non-oral agents if I had to go down that route. But then you'll see a few days later, actually, from his scores, he was doing really well. So his early warning score had gone down to 2. His respiratory rate was back down again. His SATs was okay. He was on air now. He wasn't needing a nebulizer. He wasn't needing any cannulas. Blood pressure was a bit low. But again, what I've had to find is often the doctors worry about low blood pressure and Parkinson's, and actually saying for lots of people that we see, actually it's normal to be hypotensive rather than hypertensive. So again, some people's scores have been knocked off because of this low blood pressure. So just making the staff aware that often that can happen. So this guy's temperature was fine, actually it dropped, and he continued to do really well. I actually didn't have to change his medication, but for me it was just about having a plan in my head about what I would do if, and being able to be there on the ward all the time, certainly for hours of 8 or 10, 12 hours shifts. You can see somebody and how they change and how they can fluctuate. So it was really good to be able to see somebody across the whole day to see if I would need to change or alter his medications. And I'm really pleased to say this gentleman was able to go home. My next case study is a gentleman that I didn't actually know. He wasn't part of our service, but obviously got to look after him on the ward. And this is a guy who was 80 years old. He came in following a fall, secondary to his Parkinson's. He was found to be COVID positive. He had a delirium as well, and he'd had Parkinson's for over 15 years. He had Stalevo 150 4 times daily. He was an oral dopamine agonist at 2 milligrams. He had DBS in, and he had that done a couple of years prior to that. And he also had co-banadopa dispersible as and when required. His normal activity levels was being mobile with a Delta frame. And what I'd also say is that this gentleman, his wife was also on the ward at the same time. So she was in another bay, and he was there. One afternoon, they were really missing each other, and I was able to wheel him down to his wife. And on the ward, we have these lovely little hearts that people sent in. So I got them to swap hearts. So they knew that when they were apart, they had each other's heart, which I thought was really nice. So thank you to people who did the hearts, because it meant an awful lot. I don't have this guy's news scores, but 7 days later, he's still on his nasal cannula. His oxygen levels aren't great. He's needing IV antibiotics and IVT. And his news fluctuates anywhere from 2, which is okay, up to 11. So he's severely, in trouble. He developed pneumonia. He developed problems with swallowing his tablets. So again, for his oral medications, what I did for him, because he was managing his co-levodopa really well, is actually switched all his levo across to dispersible co-levodopa, because he was doing that, and I think he needed the hit from that. I had considered, switching him over to Sinemet and crushing it, but because we had co-levodopa there already, that's what I decided to use. Again, I could have switched to non-orals in terms of a patch, or even thinking about APO if I needed to. His DBS I left unchanged because his tremors were really well controlled, and that's what he has DBS in place for. So I chose to switch him over and crush his, and use dispersibles rather than his co-levodopa or his dopamine agonists, and I did that with a conversion chart. And again, being able to see him throughout the daytime can make sure that there was no fluctuations in terms of his Parkinson's symptoms, and he was well controlled as much as he could be. Unfortunately, deteriorated further. We discussed end of life with him, but he chose he wanted to continue with active treatment. So that is what we did. He ended up with IVT and IV antibiotics still. But unfortunately, we need to move him to a side room because he just deteriorated even further. He wasn't tolerating really the oxygen very well, and certainly he wasn't responding to the antibiotics with his pneumonia. He became agitated and a bit distressed, and it's really awful to watch somebody at that stage, I think, with COVID and with their breathing. It's really, even for staff, it's upsetting. So we got him some midazolam, and that settled him. What I would say at this point is actually this ward staff were really very conscious, I think, about even the Liverpool care pathway in the past, and were very conscious that they didn't want to give people something that might, shorten their lifespan. For me, though, I think being an experienced clinician, I didn't want to see anybody in distress. So it was making sure that people were given the right medication. And certainly I think I was working with their staff nurse who'd only been qualified a few months, being able to reassure her, no, this is what somebody needed, and being able to do that and be able to fully justify the reasons. So the wife and also the family were fully aware, but the wife chose not to visit because she felt too poorly herself. So I must admit, I went home on a late shift one day, and the next morning I came back and unfortunately died.
We can all hear how difficult it is for all of the staff who have many, many years of experience, like Annette of 20 years, but how difficult it is for all the people that we're looking after with Parkinson's, as well as people without Parkinson's.
Thanks, Patsy.
I think the best thing that we can deliver is this fantastic.
Yeah. All I can say is I'm just glad that he died peacefully, but it was just really sad that his family weren't able to be present. I know the family had wanted to come in and see him and be there, but again, they were self-isolated themselves. So it's just that I've seen so many people over the last few weeks that have died by themselves, and even with ourselves present, it's still a really, sad thing that has happened. So yeah, but what we have found is people who are more advanced in Parkinson's with the DBS, actually they are much greater risk of much poorer outcomes we have found. So certainly those individuals, and we've got evidence to prove that and papers to prove that and research to show that as well. So just to watch out for people, who come in quite well, but actually if they have these advanced treatments, these are the guys who are greatest risk of not being able to recover from COVID. Case study 3, I'll come on to, so that's a gentleman here, you'll see COVID-19, they're saying it's a syndrome. So some people aren't fully proof positive, but they've got all the symptoms of it, so they call them COVID-19 syndrome and they treat them as that. This guy's not for resuscitation, he's a falls risk, he's infection control, and he's also on his critical medications. So he's a 78-year-old guy who came in with shortness of breath, found to be COVID positive. He'd recently been discharged having a fall and having a fractured neck of femur, and he was normally independent with his mobile frame. With his frame, but unfortunately because he had been poorly, the family decided earlier on there was a low threshold for palliation for this gentleman too. They just didn't want their dad to go through too much. Parkinson's since 2016, he's on co-levodopa 125, you see 5 times daily, and he's also on dispersibles, and he was on some Requip at night time for restless legs. He'd had TIAs in the past too. And again, you can see from here his new scores, he's creeping up there with respiratory rate, with saturation levels, he's got oxygen in place. Again, the low blood pressure that you can see, but not quite triggering off an alert just yet. Heart rate's okay, he's got a nasal cannula in place, and he's passing urine, his skin's normal. So all these things can really give you a good picture about what somebody's doing or how well they're doing with COVID. 6 days later, it's a bit of a balancing act. So we're aiming for oxygen saturation levels between 90 and 95 for him. He developed loose stools, you know, and again, I know that's happened very often with COVID, but he was found to be C. diff. So again, you've got the whole issue about shielding then, infection control. He developed a really poor swallow, and we're concerned about that. So we're thickening up his diet and fluids, giving regular mouth care, regular PD medications with him, and he's being nursed in bed at that point. So again, for me, the options I had were crushing some medication, which I did to make sure he was getting in that amount when he needed it. And if he was having problems with swallowing, I could have also switched him to dispersible, or I could switch him to all non-oral agonists if I felt that, you know, really he wasn't tolerating the orals, especially with the diarrhea as well. And I certainly had a low threshold for a reduction if I needed to for his medications, just trying to control him and keep him comfortable. And now, just seeing him on the ward today, I would love to say he's on normal diet and fluids. He's doing really well. He's up with the physiotherapists today. He's now negative for his COVID, and his discharge plan should be in place. We're just hopefully rehabbing him. And the difference that I've seen the last week is just amazing to see his little bright face. So that's a real celebration for me that this guy is hopefully going home very soon. So that's a really nice story, and that's a nice positive one for me. I suppose the things that I wanted to consider are with COVID-19, I've seen oxygen levels drop really dramatically, very, very quickly. I've seen a few people die very suddenly with pulmonary emboli, you know, and again, some people look very, very well, quite young as well, suddenly dropping off and, you know, sudden deaths. We're looking out for signs of sepsis, you know, we're looking out for delirium, which I think is a huge issue across the whole of the world that I've seen. But I think it's really important to agree the ceiling of care early on. And I think it's really important that we speak to people with Parkinson's, we understand what they want. It doesn't mean to say we won't look after people, or we think that actually if you come in, that's it. But I think it's having those sensible conversations. And there's sometimes I think, you know, it's important to have those earlier rather than later. And certainly with the doctors as well, you know, supporting them in making these decisions, because we know our guy is best, we know our family's best. And in Parkinson's, certainly we've got to be careful with those guys with problems with the breathing, problems with the cough reflex, again, because they're most at risk. Thinking about the use of non-oral agents, particularly if they've got swallowing problems or in ventilation, or certainly the diarrhea that I've been seeing, it's about thinking of options. It's about thinking of choices. If one thing doesn't work, what have we got next to try? And I must admit, it was easy for me because I was on the ward seeing them all the time. I think it's very difficult when you go on and do a ward consult to work out what you do best if you're not seeing them over a prolonged period of time. I've also seen a fair amount of increased dyskinesia, not because of their Parkinson's medication, but because of infection. So just to be wary, don't suddenly think, all right, they're dyskinetic, you need to reduce their drugs. Actually, no, there may be, you know, a marked infection going on that's going to knock them right off, making them either very more dyskinetic or going another way and being more rigid. And certainly for our patients, we've been trying to tell them, you know, keep away from cough, you know, medicines and cough remedies if they're on rasagiline or, you know, selegiline, because that can interfere as well. So just being aware of those when we've had those conversations. And I suppose I just want to give you a quick plug. So I've been working with Ray last week and putting a paper together, because I think when I've been looking at the evidence out there about Parkinson's and, you know, COVID-19, I just wanted to be able to have one place where I could find it all. So I'm pleased to say that I've had my article accepted for the BJN. So it's in press at the minute and should be coming out in the next few weeks. So thank you very much, and thank you for listening.
Thank you very much, Annette, for that very personal experience, which is obviously cutting edge. And without further ado, I'd like to introduce Alison Leake, who's going to talk us through the management of people with Parkinson's who have had deep brain stimulation during COVID.
Thank you, Patsy. I mean, I feel quite humbled following Annette, because I have maintained full time in the movement disorder service at St George's, and I don't have the same personal experience to share as Annette had, and maybe she can chip in regarding her experience with DBS for those who've got COVID, because I don't have personal experience of that. I gave some advice early on during the real significant point in the pandemic on a patient who had DBS in our trust, but have no contact with people in the trust with DBS since then. So this is going to focus really on our services and those around the country for those with DBS, and touching on some of the patient relevant aspects. One of the early papers from Antonini and Ray Chowdhury regarding case studies in Parkinson's disease for patients who had COVID highlights some cases of patients with advanced therapies. But again, I think we're bearing in mind that this paper was out quite early, in the pandemic, and I suspect, you know, experiences have you know, there are more experience now, but also maybe changing in how we've approached the management of patients with Parkinson's disease and COVID in the hospitals as well, and with COVID patients. One of my colleagues, Kath Parry, is working in intensive care with COVID patients, and I've been in a lot of contact with her, and I know that the approach has changed during the time she's been working in ITU, with some variations in how we're looking after people with COVID requiring intensive therapy at the moment. So this case study paper from this group had one case where the patient had DBS in situ and had COVID positive swab results. This person, as did majority of the patients in their case study cohort, required increased levodopa therapy during their COVID positive experience, but did not require any invasive intervention in intensive care. Just required oxygen therapy and went to rehab from discharge at hospital. So this particular case was positive. The cases are from either King's College Hospital or from Antonini's cohort in Italy. The case study presented also 2 cases of patients with duodopa. It doesn't say whether they were London-based or Italian-based. Both patients requiring intervention with CPAP, and both sadly passed away. So that is the experience that I've seen in the papers so far related to DBS and COVID. But if Annette has anything she wants to share, then I'm happy to let her do so. So the things that really are specific to our patients with a deep brain stimulation is obviously all of the things that we consider when we're looking after patients regarding their medication. But from a DBS perspective, certainly those who have got non-rechargeable batteries, is making sure that we're keeping up to date with their battery checks, and that we are very aware if their batteries are starting to run down. We wouldn't want to allow patients to have a complete depletion of batteries during this period, or any period, of course. Having spoken to one centre for DBS right back at the very beginning, they were putting into plans for patients who had batteries which were starting to deplete, about how they would manage that if they were high-risk patients and they wouldn't be able to bring them in to have a battery change. And that might have included slowly reintroducing different levels and higher levels of Parkinson's oral medication, and slowly reducing the DBS for that patient, so that we could switch them slowly to medication from DBS, to allow a smoother pathway rather than allowing this to happen in a sudden way. But that never came. I've spoken to this clinician this week, and that never happened. Nearly every centre that I've spoken to who do DBS have managed to continue to replace batteries if they've needed to during the COVID period with restrictions. We are able to make changes to people's DBS systems, certain parameters via the patient remote controls, and to adjust any settings to help with the symptoms that they're experiencing. There have obviously been issues in centres patients who've had DBS implanted just prior to the COVID starting, and who are awaiting programming, and those are still on hold, as obviously this is quite an intense time with a patient, you know, half a day potentially. So bringing them into hospital at the moment for that is challenging. But I know, again, in Bristol, they are starting to consider that in the coming weeks, with strict protocols to bring these patients in hospital, such as testing for COVID shielding prior to coming in. Patients who are awaiting assessment and surgery, it's very important to keep in touch with those, which we are doing, so that they know that we haven't forgotten them. We are looking at St George's about how we can start some remote aspects of assessment, so we make sure we've got patients coming through and there's no further delay. So it's really important to keep those patients informed. I think for people locally working with patients who've had DBS but aren't part of a DBS specific service, I think it's important to make contact with your local DBS service to see what their availability is and how they are running. Having spoken to members of the DBSNA the other evening, all of the centres that we're involved in have got elements of their service maintained for their clients. So if you're worried about your DBS patients, please do contact your centre and find out what their availability is. Like everything else, we're doing video and telephone consultations. At St George's about 2 weeks ago, we have started to see some urgent outpatients for patients who've got DBS who are struggling, and this goes across the board for patients who've got Parkinson's, dystonia and tremor, but it's predominantly been the dystonic patients we've needed to do. We're keeping contact with our vulnerable patients. I think that's very important to do. Some of the points that Annette has already raised, I think for patients who may be positive with COVID, they are prone to diarrhea and nausea and GI symptoms, so maintaining absorption of their medication is key. Annette mentioned delirium, and Kath Parry, my colleague, has also mentioned delirium. For her, it's about the fact that these patients are very, very heavily sedated in intensive care. And so coming out of the station, she is experiencing a high percentage of patients having delirium. Dysphagia and speech problems, I know from anecdotal information from people who've had COVID that are colleagues at work, but also from some of the patients, that swallowing and speech can be very, very difficult in those patients who are managed out of the intensive care arena particularly. So those are important things to consider. And there is some speech and language therapy availability with strict protocoling for patients with dysphagia. Anxiety and stress, we know, are very much symptoms of people experiencing COVID, as Annette has said, with regards to the severity of the symptoms, but they are impactful symptoms for people with Parkinson's disease anyway, and how that impacts how they are with their Parkinson's. And as Fiona will very clearly state, the reduction of physical activity and social activity for our patients is having a big impact. And as I said, it's about supporting our vulnerable patients, and if we do want to start seeing them in clinic, is talking to each individual patient and their lead clinician, and considering ourselves whether or not it is a viable option to bring them in as an outpatient to be seen. What would we do to reassure them, to protect them, and to protect ourselves if we felt that that was an appropriate thing to do. And that is that.
Thank you very much indeed, Alison. What I'm going to do to save time is that we'll have our next presentation, and at the end, if we have time, we will do questions and answers. If we run out of time, we will answer your questions online. Louise, thank you.
Okay, so what I'm going to talk about is a gent who had PSP and has made a remarkable recovery, and I'll talk a little bit about some others if I've got time. So it's a gentleman who's 74. He's had PSP for the last 2 years. And he's done very well, but he falls frequently. And early March, they were on holidays in Turkey, had a lovely time. And when he came home, he fell on top of his wife, and they both had a long lie at home. She damaged her knee and her ankle. He attended A&E because the ambulance was called, had a CT head, nothing new found. However, he started coughing while he was in A&E. So they obviously swabbed him, and he was positive. He was admitted to the COVID ward and was treated with high levels of oxygen, and actually recovered very well. He had some delirium, but they were starting to plan his package of care because his wife couldn't care for him as much as she could in the past because she was on crutches. Unfortunately, he developed diarrhea, but his wasn't COVID related. He had giardia, which he developed while he was on holidays in Turkey. He was then taken out of the 5-bedder and put into a cubicle on his own. While he was in the cubicle on his own, he became quite distressed, quite confused, and was unable to use his telephone to contact his family. Physio and OT went in to get him up on his feet, so it started to orientate him rather than just being in bed. And then probably about 7 days into his recovery, he started to manage his own technology as his delirium was improving. He was discharged home after 18 days with a package of care. The occupational therapist went out and did an environmental home visit. and his mobility was very poor. When he went home, he fell exactly the next day, and the advice, I don't know who from, to the wife was, oh, keep him immobile and we'll come back into the house at some point to mobilise him. Well, luckily for us, the wife, as our carers do, ignore advice if they don't agree with it, and got him up on his feet. And the daughter bought some static pedals, and I've had a lot of contact with his family. So I saw him on the ward. I haven't seen him at home because I haven't needed to, but they've given him some pedals for him to work with. He is now virtually back to himself, walking daily with his wife. He wears a reinforced peak cap as opposed to a scrum cap, which we normally provide. They bought it on Amazon. He's got one at every colour to match his t-shirt. So it's all reinforced around here, but it looks like a normal cap. But the biggest problem both him and his wife have said is the fatigue and tiredness, and it is overwhelming and it consumes him beyond belief. So I've spoken to her this morning because I ring them quite frequently. And what she said is, yeah, he's almost himself. We've got another week or so to go, and I think he'll be back to himself and not so tired. So my experience of patients being either in hospital or being having COVID in their own homes is irrelevant to their age. So I've had a lady who was 50 and a gent, well, he's 89, that have all survived and had remarkable recoveries. Again, it was the tiredness and the fatigue that lasted a month. A few of them have lost their taste and have gone off their food. And one of my gents, who's 88, in a residential home rather than a nursing home, he's an Asian gentleman and has lost considerable weight purely because he can't eat and he's lost his taste. So what they did, because he's Chinese, they got a local takeaway in for him, and you know, he's demolishing it. He doesn't like Western food because it's not spicy enough, but the spices in the Chinese has stimulated his taste. So that's what they've been doing for him. What has been quite remarkable is none of my patients have needed a change in their medication, and most of them said that Parkinson's itself hasn't deteriorated. It's the symptoms of COVID and recovery of COVID that has caused the biggest problems. So my question is, there's a massive role for rehabilitation in the community, and I haven't commented on this because I know Fiona is going to deal with it. But I suspect our roles will be more in the community, because I don't know how we're going to bring our patients into group exercises in the future. So there's a lot more questions than answers. But majority of my patients are missing their exercise groups. They're missing the support groups. It's how we can reintroduce those and transform the way we're working into a different model for the future for rehab for our patients. Thank you very much.
Thank you, Louise, very much indeed for your wonderful overview.
Yeah, I can answer that. I put a protocol together because I've had an awful lot of telephone calls off patients, and because of communication problems with husbands and wives on the telephone, and I haven't always been clear of what the problem is. I put protocol together of how you manage people in the community about donning and doffing and what you do when you get into the community. I have shared it on the Parkinson's website. Very simple. Patients understand what social distancing means. The biggest problem is resisting yourself not to give someone a hug. You automatically want to shake their hands. I'm a bit huggy, as you know, but I want to hug them. I do shake their hands because I've got gloves on and they're fresh to go in. I carry a bag in the boot of my car that's got all my PPE, and I leave a washable bag or wipeable bag in the hall with extra stuff in it. So my blood pressure machine is in there and I only use it if it's necessary. I've got Clinell wipes in a glove, so I can wipe surfaces as I'm coming out. And I did start asking the families to dispose of my PPE, but I've stopped doing that because I take a little polythene bag. It's actually one of my food recycling bags, and I doff and put it in there and then dispose of it myself, as opposed to asking the family. So yes, I can share that because it's on the PDNS website. So it's quite simple and you feel quite safe. But the biggest thing is you've got to ask them if they're well, and are they symptomatic of any cough or any unusual symptoms that the older population are having. But I've done quite a few home visits. I'm actually setting up switching someone from apomorphine pen to pump in the next 2 weeks because he's struggling. So I'm risk assessing every patient. Thank you.
Thank you, Louise. And if we can move on now to Fiona, please.
Okay, so I'm going to talk a little bit hypothetically because I work in an outpatient department for Parkinson's, and obviously we haven't been functioning normally. And I've been the only physio left behind to manage things on telephone. I did do a home visit earlier this week, which was an emergency, and I am bringing a patient in 10 days' time as, again, a sort of emergency. But within the next 3 or 4 weeks, we're looking at how we can bring some patients in, but it's very much, you've got to look at all the risks. So I'm going to just run through some of what the papers have said about COVID and about rehab. There are a few papers on older people in general, which obviously a lot of people with Parkinson's are older. A couple on Parkinson's, and 1 or 2 things on rehab in itself for post-COVID. So I think this paper, this one, I don't think this one has been mentioned before. They're all very recent papers, obviously, because COVID's so recent. But this particular paper by Patsy looked at the consequences of just people being in lockdown on their cardiovascular fitness, being stuck at home, not out exercising, giving them reduced muscle strength and muscle mass. And within that paper, they'd also referenced another study that showed that 3 months of no exercises, or any exercise, leads to a decline in people's physical functioning and their mental health and their quality in life in physically active older people. So whether they've had COVID or not, the people that we are going to be seeing at the end of this 12-week shielding thing, which may not even be over after 12 weeks, are going to be an enormous amount of deconditioned people. And obviously they also have an increased falls risk and fractures because of the social isolation and the lack of perhaps the cognitive decline that goes with that, lack of vitamin D, not getting out in the sun, particularly if they don't have a garden. So there are those problems just in older people generally. And then this is a rapid clinical review that was done again for older people, which hasn't been published in a journal yet, but it's been accepted, showing that those who were at higher risk of being more ill with COVID were those who were older and those with comorbidities. And obviously Parkinson's is one of the comorbidities. And also an increased risk of physical and mental health problems in older adults who were socially distancing and isolating, and loneliness being a big issue. The loneliness leading to more impaired cognitive function and increased risk of frailty, which all of those are real dangers for our patients. And this is from a part of our website in our trust, which they put together a supportive I guess a place people can go who've had COVID to get support for how they're feeling once they've gone home. And it lists these effects as being the kind of things that they may be still feeling even though they've gone home. And some of these have been mentioned already. I won't go through the ones that have been mentioned, but it includes sleep problems and nightmares or flashbacks, particularly if they were in intensive care, which I think is a normal thing for people who've been in intensive care, and post-traumatic stress disorder. And then it leads them to this page that I've just done a screenshot of, which points them to places they can go for support. So the support hub set up by Asthma UK and the British Lung Foundation, I've actually put the link on that slide, where there's a lot of information on how people can get, what they should do if they're experiencing some symptoms. And again, on our trust page, they've taken this from the Lancashire Teaching Hospitals Trust, with links to what to do depending on what the symptom is that they're feeling. So there's support out there, but it's very much online support, because the rehab side of things hasn't picked up in the outpatient sector yet. People who've been discharged into a rehab bed have had rehab, but the other rehab is just beginning to emerge. I think this paper has been alluded to already today about the outcomes of people with Parkinson's, and it particularly being worse for those who are on these advanced therapies, but also the non-motor symptoms worsen while somebody has an infection of COVID. And the people most at risk are those older people with Parkinson's who've had Parkinson's for longer, and they're more likely to die. And I think we've picked that up from everybody else's really excellent case studies. But this paper that was done by Helmich, one of the first papers to come out on COVID and Parkinson's, points to what they call hidden sorrows, which are the sad things about COVID, but also the emerging opportunities that we have leading out of it. And the hidden sorrows are the worsening of people's symptoms, the reduced efficacy of their medication, from the psychological stress of just being locked in, never mind having COVID, but with COVID as well, and that marked reduction in physical activities, particularly aerobic exercise that's so important, leading to a worsening of their Parkinson's symptoms. But from those things, we've all had to think outside the box. So there are loads and loads of online classes now that people can join. Parkinson's UK has 2 live sessions a week, which then go on YouTube. But there are singing groups online, and you can find all sorts of exercise programs online, which is great if you're online. But a lot of our patients are not online. So yes, it's an emerging opportunity, but it's not the only answer. It's really important to hopefully have already taught people self-management strategies to manage some of the things, but we can also perhaps by telephone or maybe even again online do self-management techniques with CBT, and encouraging people to take up these exercises. But for people who are exercising, the paper says it needs to be adequately dosed. I still think that's an enormous challenge for people stuck at home. It's a challenge for all of us. How many of us are actually exercising at our normal levels? I have to put my hand up and say I am not. I would love to be, but I am not for various reasons. So it's harder if you can't get out and use the same equipment at the gym or whatever. And then this paper was written by 4 consultants, one of whom works in our trust, about the need for rehab for post-COVID patients, and particularly for people who've had COVID. Well, it actually targets people who've had COVID, but I think it's the whole thing's about rehab being the sort of, it's not always had that importance it's perhaps needed. And it's highlighted the complications for those recovering from COVID, which we've talked about today, fatigue and cognitive impairment, and needing a person-centered approach to rehab and a whole multidisciplinary team, but also highlighting those challenges of how do we deliver it when we're not doing outpatient services and when our community services are still only doing the really, really urgent patients, and a post-COVID patient isn't necessarily being seen as a really urgent patient anymore. It has got in that paper some suggestions of the things that the programs should contain, including exercise and practicing activities so that they can be more independent, including emotional support, psychological support, and education and equipment. So some of that's the normal side of rehab, but it's really useful to have it in a paper, because I think we're going to need some of the people making policy decisions to really pick this up and put the money behind it and put the policies behind it that really enable rehab to get going quickly. We can't wait too long, because these patients who are in are going to be deconditioning again now they've gone home, and we really don't want that to happen. There are rehabilitation standards post-COVID on the Chartered Society of Physiotherapy website, and saying that people really need to have it. And yes, we do need to have it. It's just not there yet. So I think our challenge is finding ways to do it safely for our patients, and that may well be home visits. It may be doing online group sessions. I think we're going to have to use a bit of everything. But whatever we do, I think we've got to highlight the need for it and continue being there for these patients who are at huge risk. And that's the end of my bit.
Thank you very much indeed for that marvellous presentation, and my colleagues. We are left with a little bit of time, and I have some questions here. The first question that I'd like to put to Louise, please, is people with Parkinson's, are they more vulnerable than the rest in getting COVID-19?
No, I think in the beginning when the guidelines came out, the Neurological Society felt that they were probably more at risk, purely because of the complexity of their illness and depending where they were in the disease trajectory. But actually the most up-to-date evidence is saying they're no different from the rest of the population at getting COVID. However, their recovery may be different because of respiratory problems and the whole where they are in the disease progression. So I've had a few questions from some younger patients who are still working. Should they be shielding? Should they be working? And my advice has been to take follow government guidelines. And two young women that work in the hospital, and they've continued to work, but their managers have protected them as not going into high-risk areas. But our more elderly, frailer population, they're at the same risk as anybody else who's 70 and above. So no, I don't think they're any more at risk, but I think the outcomes could be poorer for them. Would you all agree?
I think this is a question that's being frequently asked of all of us.
Yes.
Fiona, I wonder if you might be kind enough to answer this question. How can we begin to rehabilitate those patients who have had COVID-19, whilst the opportunities of community services are not able to meet needs? And I know you've covered a little bit of that in your presentation already.
I think from a therapy point of view, I think we are perhaps going to have to, although I work in an outpatient department, I do occasional home visits normally, but I think we're perhaps going to have to look at, perhaps we'll have to be starting to do some of those roles temporarily, maybe not temporarily in the end, where we can offer a service to our patients in their own homes, because I don't think we can afford to wait for all the services to catch up. And I think we have to identify the people most at risk. We've done a risk matrix with all of our patients, nearly all of our patients, where we've identified whether they're high risk, medium risk or low risk. And we have to make sure those high risk patients are accessed really quickly by whichever member of the team they need. And maybe for those that we can weigh up the risks, we bring them in with all those things in place for an outpatient department. I don't think we probably ever going to have the option of a rehab facility for these patients once they've gone home. I think they probably do better from home, ideally. And I just think perhaps we're going to have to rethink how we work our services.
Thank you. And I think that's coming through in all the presentations. It's looking at things, it's looking at the opportunities from being in situations with COVID of how we can improve the care that we can offer to people with Parkinson's. Listening to everyone speak, I think it really drums home, particularly to me, and I'm sure to all the listeners here today, of how varied the condition is. And one thing I'd like to point out as well, listening to it, is just to be ever so careful and to be vigilant about your people who are coming in with Parkinson's, you know, who might have what seem like symptoms are, but, you know, if they have felt nauseous, if they've had diarrhea, if they've had bowel problems, the absorption of the tablets could be really badly affected. And, you know, if people are coming in with sweating, with muscle wasting, with anxiety, with high temperatures, low temperatures, not to rule out the fact that what we might be looking at here is a neuroleptic malignant syndrome because people aren't getting their medication. And that may well be a little bit confusing. This is something that we're working very carefully with Parkinson's UK and the Excellence Network, is to try to make this a never event. Another question here, and I wonder, Annette, if you might answer this, please. Considering patients with Parkinson's are on complex treatment regimes and prone to fluctuating symptoms, anything that you might be able to offer to help people with compliance, please?
What I would say, Patsy, is it's really important to have a partnership approach with all medications. A number of times I've seen people being put on medications that aren't explained to them properly of how they work, when to take them, potential side effects. And I think for me, it's all about a partnership, talking to people about what they want, you know, what the options are available to them, having different plans like I often do. So one might suit one and one might not suit the next. So I think it's really working out what the person wants, looking at what their control is like, and actually having sensible conversations really about, okay, then this is what we've got. You know, and actually, you know, people who are poorly, who have marked motor fluctuations, will make sure they take the medication on time, because it means the difference between independent or not. So for me, it's about working in partnership all the time, looking at all options. It's not for me to decide what somebody should be on, it's for us to work together and work out, okay, then what would be best for them.
Thank you. And Alison, I'd hate you to feel left out here with no question. I have one here about people who have device therapies, particularly at the moment, trying to keep people out of hospital. What plans do you have in place if these devices should fail?
Thank you. I mean, for all of our, our duodopa and our apomorphine patients, we contacted them all as we were entering this difficult period of time. We spoke to them about it, and we wrote to them and to their GP about an alternative plan to treat them. So we reiterated the duodopa emergency oral medication plan, and for our apomorphine patients we devised an alternative plan for those to make sure it was current in their medical records at their GP practice. Also made sure that they had the helpline numbers for both the healthcare at home and the apomorphine nurses. For duodopa, there are no tube replacement opportunities at the moment. Obviously, because endoscopy is, if running any service at all, it's a very urgent, acute service they're running. So there's no opportunity to replace tubes at the moment. For our DBS patients, as I said, it's about making sure for those patients who are who have non-rechargeable batteries in place, that they know how to check them and to notify us when they get any notification that their batteries are wearing down. And for patients who have rechargeable batteries, making sure that they, that they are doing that effectively. Those patients are slightly more unique. We don't have the support of a nursing team to keep an eye on those patients in the same way. There isn't a helpline for those patients. So it's a matter of keeping in contact with those at-risk patients. As I said, the team in Bristol were thinking some of their patients that were going to run out, were going to have problems with their batteries running out, and they were too high risk to bring in for battery replacement, that they would look to switch them gradually from DBS to oral therapy, but that never became an issue. And hopefully now, if we can continue to manage this outbreak ongoing, then we won't be finding ourselves in that position again.
Thank you. And one question maybe to the panel here. How do you envisage reintroducing and transforming the Parkinson's service of the future?
There's a whole talk in itself, is it not?
Yes, it is indeed. Yes, it is. Maybe everybody might join in with just one thing that they found so far.
I think we will be doing a blend in the future of face-to-face and virtual appointments, depending on each individual patient and their want, their ability, their want to do it that way, to have access to technology, etc. But they may, for those patients who are not requiring such frequent face-to-face, they could have an annual appointment with their consultant, which could be face-to-face, and 2 appointments with their nurse, one of which could be virtual. maybe. It will cut down on travel to hospital for patients who are coming a long way. It will mean that we've got more clinic space in the hospital to increase clinic capacity, all those sorts of things. That could be a benefit for those who want it and those we feel are a suitable candidate.
I feel that clinics will be a mixture. You know, when we're sitting in clinic, we may have telephone review with some, we may have a face-to-face in the middle of it, then we'll go back to a video. I just think we'll have a mishmash of all type of whatever's available for the patients. But I think the face-to-face contact in hospital clinics, in and out patients in the hospital will be less. We may have to go into the community and have appointments in GP surgeries or community hospitals. And I think the future has just been brought forward earlier than what it was going to be. But I think the group sessions will disappear, won't they, for quite a while.
I'd also like to see a greater use of wearable technologies. I think, you know, it's all very well, and if we've got these technologies now, it'd be really nice to have something that's going to support us in our clinical practice decision making. And even we know that people are on lockdown at the minute, just understanding how much activity they're actually doing, be able to track and monitor that and be able to kind of compare that, I think would be really helpful. So if people have got activity monitors, really use them, look at them, understand what you're doing, and then think of ways of actually improving that, because they can be really measurable things. At the minute, you know, it's like your guesswork. We know what people like filling out diaries, but actually we could have more technologies we could have access to. That's something that I would desperately want to have.
I think there's another opportunity as well. I've only had, I think Fiona may have been involved yesterday. I've only had the chance once to do some joint UK stroke Italy work in a patient group environment via Zoom. And I think it's bringing people internationally closer together. I think we have an opportunity to bring patients internationally closer together, to share experiences. The Italian group does some excellent dance groups, as do we. You know, they're willing for us to join in with their early Saturday morning dance groups in St. Peter's Square. And, you know, there are great opportunities for us to use technology now to offer patients and carers and families support networks, learning from everybody.
Yeah. Can I also have a plug for the more webinars for people with Parkinson's and their families? So there were Patsy and Alison, we did a webinar this week. We've had over 500 views just this week on it. I think it's really important that people do feel isolated and actually being able to speak to people, you know, who are experts or kind of got some knowledge and understanding. So I think hopefully opening that up more to people, so because people are missing their support groups. So it's just, I think, different ways of working for all of us, different, you know, new technologies, and let's make the most of it.
A lot of my patients have supported each other through Zoom. So, they've got together and those who've got the technology have started meeting via Zoom. So they've got that support which they need.
Great.
I think the challenge for therapists is we're hands-on people.
Yeah.
And I've already had to, you know, there's only so long you can leave a pile of new patient referrals. So we've developed a therapy assessment to do by telephone for either the OT or the physio to do. And I think probably that will be something that we will move to do a bit more of in the future to minimise the amount of time that the patient has to spend when they do come in, if they do come in. Nothing will ever compare for me than actually seeing the patient walking. I might have to get used to watching video. I think send me a video or watch the video online, but I'm still looking for the right approach for the patient who's not online.
Thank you.
I'd say watch the space.
Yes, absolutely. Now we have another question here of how much exercise minimum daily, and I would like to point everyone to the next seminar, which is going to take place on the 5th of June at 2:15 with Fiona and Baz Bloom to answer those questions. And once again, it's going to be supported by our colleagues at BL, which we're ever so grateful for, and also Sarah Gillett and her team from the Neurology Academy will be there to support it. So I'd like to draw this meeting to a close today. I'd like to thank my expert panel, BL and Sarah, for all their input. I think it's been sharing a wealth of experience and so much research to take forward, which I think will be invaluable to people with Parkinson's. So thank you all very much. Stay well, stay vigilant, and hopefully join us on the 5th of June. Thank you. Enjoy the weekend. Goodbye.